Hi, I'm Dr. Rena Azar, and today I'm going to talk a little bit about bladder function. I'm going to talk a little bit about the relationship between symptoms of the bladder and anatomy of the bladder. So firstly, I'd like to say that most of the time when we're fixing problems with bladder function, we're fixing things that are related to damage done during childbirth. Now, people can have bladder dysfunction from damage that occurs with heavy lifting, or even if you have kind of a tendency toward weak tissue, it could be damage that's done by kind of normal lifestyle things. But the great majority of people who have significant dysfunction of their bladder have it because they had damage during childbirth. And children actually do two types of damage. They do firstly anatomy damage. Anatomy damage is related to the tearing, pulling, tugging of tissue, muscle, fascia, ligaments, tendons, etc., all the support structures of the bladder. And when these things give way, then the bladder shifts in position. And when the bladder shifts in position, then it will not work normally. The number one symptom we see when bladders are out of position is stress, urinary incontinence, leakage with coughing and sneezing. And I always explain to people that when I do surgery, I fix the anatomy. When I fix the anatomy, the dominant symptom that I fix will be leakage with coughing and sneezing. However, there are other symptoms that can be very problematic to people, specifically urinary frequency, urinary urgency, and difficulty emptying your bladder, which can be hesitation, slow stream, difficulty emptying all the way, secondary voiding, which is where you urinate, and then you start to stand up, and then you find that you've got more in your bladder. So the reason for bladders behaving poorly with those types of symptoms could be severely bad anatomy where things have drooped out of position significantly. And I'm going to come back to that in a minute. However, it's really important to know that oftentimes the symptoms of urgency, frequency, and difficulty emptying are related to neurologic damage. And this is how neurologic damage works. There are muscle fibers, but there are also nerve fibers around the bladder. These nerve fibers come together and go up the spinal cord to the brain. They talk to the brain and allow the bladder and the brain to communicate. So when our bladder is full, it generally is appropriate and tells the brain, hey, I'm 50% full. A little while later, it'll say, hey, I'm 90% full. A little while later, it'll say, hey, I'm 95% full. It gives the brain notice to find a toilet. But bladders that are neurologically damaged, those nerve fibers are damaged, the bladder will, firstly, sometimes it feels full when it's not, or sometimes it gets full and it doesn't realize it until the last minute and doesn't give the brain adequate notice to find a toilet. That results in urgency, where the bladder is very, very full and it wants to make it to the toilet right away. Another symptom of neurologic damage are bladders that do not listen to the control of the brain. So a normal bladder feels full and it says, looks around and says, okay, I'm going to find a toilet. I want to go to the bathroom. But the brain says, no, this is not an appropriate time or place. You are not going to empty right now. You're going to relax and you're going to let her find a restroom and walk all the way to that restroom, go in the restroom. She's going to turn around. She's going to turn the light on. She's going to close the door. She's going to turn around again. She's going to sit down on the toilet. So you're to wait for all of those steps appropriately. And neurologically damaged bladders oftentimes do not recognize the signals from the brain, do not listen to the brain's control. And the result is a difficult time getting to the toilet without having to rush or without getting some leakage. So these are symptoms of urgency, and frequency can result when the bladder feels full constantly. Retention symptoms come from a different relationship. So the bladder muscle is a balloon-shaped muscle, has all these muscle fibers that are go in a circle, and they have to contract simultaneously to get good emptying. That is called synchrony. The fact that all the muscle fibers contract at once to get a good emptying effort is due to the fact that the brain coordinates all of those contractions. And if you have neurologic damage around the bladder and the nerve fibers don't get the signals correctly, then you don't get synchronized emptying. And that can end up looking like a bag of worms, like where there's contractions over here, instead of a nice synchronized emptying effort. And so people can get symptoms like hesitancy, where the bladder doesn't release the urine, or slow stream, or poor emptying and feeling like you're not getting emptied all the way, or stop and start stream. Those are all related to urinary retention or neurologic damage where the bladder can't listen to the brain. like most things in life, there's nothing that's black and white. So unfortunately, stress incontinence is not always exclusively due to the position of the bladder, but is by large and far the most common reason is bladder damage and the shifting of the bladder position. And urgency, frequency, and retention are not always from neurologic damage. So the area where I will see people having problems with urgency, frequency, and retention is when the bladder is very out of position. It's very hanging down low. There's actually a physical reason why that bladder can't empty well. It can't push the urine up and out very easily because it's hanging in a lower position. So, and also because it's in that lower position, it's jiggly when it's full. It has a real difficult time holding volume. And so people get frequency and urgency because the bladder feels very full when it's very, very saggy. So when I see somebody that has a significant anatomic defect, I know that urgency and frequency in that situation, as well as retention, can result from the position of the bladder. So oftentimes in people who've got very bad anatomy, if I don't see symptoms of significant neurologic damage, we will do an anatomy fix, which is surgery. And then we'll come back and reevaluate later if we have persistent symptoms of urgency, frequency, and retention. But sometimes in people who have a good anatomy fix and physical therapy afterward, we can override not only stress urinary incontinence, but we can correct frequency and urgency as well with a surgery. And that's the reason why sometimes bladder surgeries don't fix everything, is because there's neurologic damage as well as anatomic damage.